I want to start with this talk just to go over something that I think is a work in progress, but something relevant, I think, long term for our patients with glioblastoma. And I think it's becoming more and more relevant as we start seeing clinical trials involving immunotherapy come into the landscape. And so I'm kind of skipping ahead and kind of discussing that we haven't really made a lot of progress in glioblastoma in terms of standard of care. We still talk about maximal safe resection, conventional radiotherapy, chemotherapy, and the most recent advent is this alternating electrical field with the tumor treating field. But none of that's really significantly improved overall survival beyond about 1.5 years. And so when we talk about like addressing these patients that come into our hospital, you know, a new onset seizure, complaints of headaches, nausea, vomiting, a new neurological deficit, or just an incidental workup as an outpatient that gets sent in through the ER and then transferred into our hospital. The question is, you know, how do we manage these patients? And a lot of times we bring them in, admit them to the ICU or the intermediate step-down unit. We, you know, reflexively give them a lot of steroids, seizure prophylaxis, and then get imaging to figure out what exactly we're going to do. Some of the things we lose out on in terms of managing these patients in the outpatient setting is really giving them an opportunity to hear about the disease process, get counseling as far as their perioperative support structure, and then talk about, you know, clinical trials and second opinions. And one of the things that I think a lot of glioma surgeons are recognizing is that a lot of what we do in the first several days of diagnosis ultimately impact these patients' long-term survival. Whether or not we get them enrolled in clinical trials, how much, you know, we decide to resect as reasonably safe, and who we send them to as far as getting the resection. Some people have a biopsy done in the community and get started on chemotherapy and radiation, and that's it. And then part of that component is that we kind of reflexively give people a hefty dose of steroids. And the reason for that is that, you know, it's very effective in terms of managing glioblastoma symptoms. It's you know, we give them dexamethasone, which is synthetic glucocorticoid. It's empirically widely used for vasogenic edema, and it does a great job in terms of relieving a lot of the symptoms that people have. But the concerns with dexamethasone and many glucocorticoids in general is that it has a lot of direct adverse effects. And that includes hyperglycemia that requires the addition of insulin in people who previously didn't require it. GI bleeds is something that we used to commonly see before we started using PPIs and H2 blockers. We see late in patients steroid myopathies that really impair their function in the home setting, requiring lots of readmissions for rehab potential, and then it confuses it with potential progression of disease. People develop steroid dependence and adrenal insufficiency, and then they you know, we see often enough people who are 1 or 2 years into therapy with these like significant Cushing-like features. And then there's these potential adverse effects that we're only starting to recognize with the advent of these new immunotherapeutics. And that's that it can interfere with the body's native immune system, interfere with our immunotherapeutic agents, and potentially actually induce a radioresistant phenotype in the tumor itself. There are a couple of papers that have looked at the effects of dexamethasone in general in just normal glioma cohorts. This group out of Memorial Sloan Kettering in New York showed that patients who were on dexamethasone had a significant difference in terms of overall survival in both their own institutional cohort, the original Stoop temozolomide cohort, and a German glioma network cohort. And multiple other studies have shown in smaller retrospective instances that it impairs the effectiveness of adjuvant therapies, both steroids at the time of radiation, as well as in instances where there's no radiation or chemotherapy even being used, such as in the tumor treating fields cohorts. Secondarily, you know, there's been some discussion about how much steroids to give in the perioperative period. And there have been small cohorts that have suggested that high doses of steroids are actually worse in terms of long-term outcomes. The problem is that none of these are prospective, and it may suggest that people who have more severe disease require more steroids, and that's the effect that we're actually seeing. So the goal of this, in addition, there's other studies in non-brain tumor patients that suggest that the use of steroids can negatively impact the effect of immunotherapeutics like PD-1 and PD-L1 inhibitors. But the goal of this project is really to understand how we use steroids, particularly dexamethasone, in the perioperative period, why we use it in the way we do, and then try to create a framework to better titrate how much we give and minimize the negative impact of overprescribing dexamethasone. And I think there's a lot of issues that we had to address and try to really come up with a good framework to tackle this issue. I think it's so ingrained in our practice, and there's so much dogma involved that it's difficult to overcome. And so there's really three areas that we wanted to tackle, and kind of gotten to 1.5 of these. The first is that we just wanted to observe how our clinical practice behaved. When we decided to use certain amounts of steroids, how long we kept them on for, how long we tapered them for, and then what the issues were in terms of initiating potential changes. The second was to look back at our clinical cohort that we've treated here and to see if there was a significant impact of steroid use in terms of readmission rates and long-term survival, and to see if we had any previously documented metrics for actually documenting some kind of improvement. And the last thing was to kind of develop an actual standard for which we could follow. And that's, I think, been the hardest part. And so the way we use, Decadron here at Jefferson is pretty standard practice. And it's driven, I think, largely by the admitting provider. We kind of reflexively give them a large bolus dose of 4 to 10 milligrams of IV dexamethasone. We maintain them on anywhere from 2 to 4 milligrams IV every 6 hours before surgery, and then we give them another bolus dose during surgery. After the procedure, we often maintain them on 4Q6 for several days, and then taper them over some arbitrary number of days to a maintenance dose. And there's no standard for that. A lot of it's empiric based on how we think, how much edema we think there is on the MRI, or how symptomatic they appear. And oftentimes we err on the side of doing more rather than less because we see dramatic improvements up front without contemplating the potential long-term impact. And if the reality is, giving 24 milligrams in a day of steroids actually reduces someone's overall survival by 6 weeks or 2 months, are we doing the right thing in the short term or in the long term? The other problem is that we don't really have a good metric in terms of looking at disease severity. We talk about symptoms, but when we look at actual gradation between someone who is symptomatic and someone who is not, the only things we really have are these very gross functional scores. Most people who present with glioblastoma have a Karnofsky Performance Index of 90 or 100, with or without headaches, nausea, vomiting, minor neurological symptoms. And it's a very poor indicator of actual disease-specific symptoms. There was a working group of the response to neuro-oncology to try to tease out some kind of corticosteroid-related quality of life composite metric, but it was just a proposal of a combination of several internal quality of life metrics, as well as a steroid kind of specific questionnaire related to nausea, vomiting, lethargy, and things of that nature. And the last thing that could potentially be used is looking at a quantitation of a patient's preoperative, postoperative flare MRI to determine the extent of cerebral edema and whether certain amounts of steroids is necessary. But those are kind of all metrics that are in development in the work. The next thing is that we wanted to look at our own internal cohort and see kind of what we could ascertain from our previous experiences with dexamethasone. And so we developed this retrospective intracranial tumor database, which kind of extended beyond just glioblastomas, but helped us kind of collect the data that we needed for this project. And we looked at all tumor surgeries between January and December 2012, 2018, and found the short and long-term outcomes as best as we could. We've currently got identified 582 patients with glioblastoma, and our cohort's pretty typical of the historical kind of comparators. Mean age is kind of in the 60s, very similar to the SEER database. Our progression-free survival and overall 2-year survival are very similar to what we see in historical cohorts. And what we've kind of noticed is that our remission rate is about 30-day remission rate in the order of about 10%. The problem right now is really teasing out what is the cause for those readmissions, and we're working on that, as well as understanding where our hospital length of stay is being extended. Really, the limitations of what our work is so far in the retrospective side is that prior to EPIC, the medication records are very obscured. So it's very difficult to quantify the actual cumulative preoperative steroid dose and perioperative steroid dose. Outpatient medication records prior to EPIC also are very incomplete. It's hard to know exactly how long they were tapered for and whether or not they were using steroids at the time of adjuvant therapies. And then, our documentation of symptom severity is not very precise. People will complain of nausea, but is it severe? Is it mild? Is lethargy severe? Is it mild? And I think we need to do a better job of trying to tease that out in a prospective manner. And so kind of where we're going with this and what I'm hoping to kind of work on in the coming months is really dive deeper into our database, looking into some of the archived records to see if we can get a better sense of the daily dexamethasone usage, see if we can actually quantify our cumulative steroid usage in the 2 weeks perioperative, develop some kind of nomogram that correlates symptom severity to outcomes, so that we can actually standardize the way we dose steroids, taper steroids from just a resident perspective, because a lot of those decisions are made very early on in the patient's presentation. And then try to develop outpatient metrics that we can use to kind of follow these patients long term. The other alternative thing is to actually consider non-steroidal alternatives to treat cerebral edema. There are clinical trials that are utilizing things like mannitol early on, and then in later post-surgical patients using things like Avastin. So those are things to consider, but I think they require a lot more evidence and a lot more grounding in actual data before we can start implementing things that have significant implications for patients, both short-term kind of short-term quality of life issues as well as long-term survival issues. So that's kind of where we are with this project. I want to thank the tumor division, all the attending Dr. Andrews, Dr. Judy, Dr. Farrell, Dr. Evans, but in particular for kind of spearheading the tumor database. And then 2 med students in particular who've put in a lot of work in terms of organizing and implementing the data. And that's Mike Baldessari and Lohit. And then Goli for being a sounding board in terms of all of this. So thank you.